that their oxygenation is improving. And you get decreased lung compliance. So you have sudden onset of severe dyspnea. They cannot breathe. You have hypoxemia that does not respond to supplemental oxygen. Now, can you all read this on the PowerPoint? It's awfully small, but it shows that better. Yes. I need to get my clicker. What happens is you have an inflammatory response, and there's a release of mediators. What are mediators? They're chemical signals that tell the body to do something. Okay, that's what a mediator is. All right? When you get the release of these mediators, you have increased capillary wall permeability. What happens when the capillary wall is more permeable?
More things get through it.
More things get through it. What gets out?
Air.
Water. Okay, what else gets out? It's more permeable. Protein. Okay? Capillary wall is more permeable, and that means things leak. When it's more permeable, they leak. Things that ought to stay in don't stay in, they go out. Okay? And then what happens is you get the alveoli are flooded, and there's only so much surfactant to go around. Okay? So the alveoli are flooded, and the surfactant gets washed away. So they start to collapse. Because remember, surfactant is what keeps surface tension on the bubbles, keeps them open so that gas can be exchanged. Oxygen can go in, carbon dioxide can go out. All right? Now, when you have the release of these mediators, you also have a decrease in the air-wide diameter. Okay? So when we have decreased diameter, can we get in? No. So we have an increase in, a decreased diameter, all right? So what air is getting in is not getting in as easily, is it? And we have increased airway resistance because it's tight. And we have decreased compliance, okay? And so all that does is increase the work of breathing. So now breathing takes more work, more energy, and you've got less to work with because your alveoli have collapsed. And so you have alveolar hypoventilation, and then you start getting shunting. And that whole thing about ventilation perfusion ratio gets way out of balance. So you have a subsequent injury to the pulmonary vasculature, and you get pulmonary hypertension, vasoconstriction, microemboli. What are yes?
Can you explain to me again what that intrapulmonary shunting is? I don't get it. What is that?
It means that the blood is not able to flow into the lungs. It's shunted away, goes someplace else. Okay? So you get microemboli, and you get pulmonary hypertension, and there's so much pressure in the lungs that blood can't go in and out. Remember, circulation through the alveoli depends upon not much resistance. When you start getting all that resistance. And so, when you get pulmonary hypertension, what part of the heart is affected? The right side of the lung. Right side of the heart. You get right-sided heart failure. Okay? It's pretty dramatic, and it can kill you quickly. And it can start with a slight cough and end up death by nightfall if you get someone with pulmonary hypertension. Okay? So that basically is the basic physiology of adult respiratory distress syndrome. So how are we going to manage it? We're going to intubate them. Okay? We're going to give them mechanical ventilation with positive end expiratory pressure. And we're going to treat the progressive hypoxemia. Now, what is an oxygen room air? How much oxygen? 21%, right? Okay. So if we have to oxygenate someone with 100% O2, that's a lot of oxygen. And remember, oxygen also is a drug. Oxygen therapy is not without risk. So when we look at someone who's got ARDS, we're looking at how much oxygen is needed to require an adequate oxygenation. How do we measure that? What's the best way to measure that? Whether they're getting oxygenated. Arterial blood gas. Arterial blood gas. If we have someone who's on a ventilator, do you think they're anxious? Right. So we may or may not need to sedate them to the point of not resisting the ventilator. We're going to change their position frequently. I'm not sure what they mean by proning. I'll have to look that up. I just saw that there was something on there I wasn't familiar with. Proning is laying flat, but I'm not sure why you would do that. I'm going to have to look that up. I apologize. I'm going to give them nutritional support. Can go for a couple of days. The average well-nourished adult can go for a couple of days without nutrition. But if they are going to have to be on a ventilator for a while, you're going to have to provide nutrition. And we prefer to provide it through the gut as opposed to through the veins. And we have to give them general supportive care. So do they have a Foley?
Yes.
So when they have a Foley, what are they at risk for? Infection. So we have to, they can't, yes?